So next is investigations for shocked patients. There are some general rules here. So investigation should be guided by the suspected underlying cause. So it is all about finding the reason for the shock rather than diagnosing the shock itself. So you do an ECG for the suspected MI, you do an ultrasound or CT for your trauma patients, you do an echo or CT for your massive PE, you do septic screen for your sepsis, etc. And there are certain investigations that are generic. You will do them for all types of shock because they are important to assess the severity of shock and to monitor the response to treatment, like the full blood count, the renal functions, and more importantly, the lactate, which we'll need to focus on for a couple of slides. So talking about the lactate elevation suggests shock, but actually it is not inclusive for shock. There are so many other things that can increase your lactate level, and that is without shock. Like, for example, being on metformin in diabetic patients, or drinking alcohol, for example. So lactate doesn't always reflect tissue hypoxia. There are so many other reasons for the increase in lactate, and elevated lactate levels, generally speaking, above 4, this is associated with increased ICU admissions and mortality in sepsis, not in general. And normalizing the lactate in trauma patients and in post-cardiac arrest patients, this is a really good way to monitor response, and it is associated with improved survivability. So a bit more about lactate. Elevated lactate shouldn't actually, should be interpreted in to respond to shock and some other impending disaster. So when you see high lactate in an unwell patient, badness is happening. Do not underestimate elevated lactate in an unwell patient. This is either shock or it is something else bad that is happening and you are missing. And we will come to this towards the end of the talk. So the other thing is normal lactate is not necessarily reassuring. There will be situations where you're going to face shocked patients with normal lactate. Don't be falsely reassured by this normal lactate in these situations. And lastly, having serial lactate can be very useful. What I always say to my juniors as well is, so it is like in ECGs, one ECG begets another, one lactate begets another. When you get one lactate, I would want to know what's the next reading. Is the lactate getting better? Is the lactate getting worse? An isolated number is not that useful per se. So again, some pitfalls in diagnosis of shock by lab. So labs can only suggest shock, but never exclude it. There is no single test that you can do and say, okay, test is negative, no shock. There is no such thing. A normal lactate is not necessarily reassuring because it can occur in some cases of shock.